Hey, what's up, guys? This is Sasank Med. Today I'm going to be talking about atrial fibrillation and atrial flutter, two common conditions that is present in patients with cardiovascular risk factors in the hospital. So, just to give you some background, for the people who are most likely to develop atrial fibrillation, these include people with elderly age, they're obese, have hypertension, smoking, ethanol use, or diabetes, or previous heart attack or heart failure or obstructive sleep apnea. And then once developed, the atrial fibrillation is likely to recur due to secondary precipitants such as surgery, infection, a heart attack, thyroid toxicosis, acute alcohol use, or pulmonary embolism. There's also a higher incidence in white patients and male patients. Racial, ethnic, and gender inequities persist in atrial fibrillation screening and management. So the atrial fibrillation classification is into 4 different classes. So stage 1 through stage 4. So stage 1 is patients at risk for atrial fibrillation with presence of modifiable and non-modifiable risk factors. These include some of the conditions or the risk factors that I've stated previously. Stage 2 is pre-atrial fibrillation, which has structural or electrical findings that predispose to atrial fibrillation, such as atrial enlargement or ectopic rhythms. Stage 3 is atrial fibrillation spectrum, which includes paroxysmal atrial fibrillation, classified as 3A, which is less than 7 days, persistent, which is 3B, and is greater than 7 days, and long-standing persistent atrial fibrillation at 3C, which is greater than 12 months. Or status post-successful atrial fibrillation ablation, stage 3D. So stage 4 includes permanent atrial fibrillation, in which there's a decision to no longer pursue rhythm control. So you have a patient with new onset atrial fibrillation presenting to the hospital. When you're first evaluating this patient, you want to get a history and physical, and you want to ask questions such as the presence and timing of their symptoms. Do they feel any palpitations? Do they feel any shortness of breath? Do they feel weak or unable to do daily activities? Any history of hypertension, diabetes mellitus, valvular disorders, heart failure, angina, congenital heart disease, obstructive sleep apnea? Is there a family history of atrial fibrillation? Any acute precipitants that may have caused this, such as ethanol use, thyroid toxicosis, sympathomimetic drugs, surgery, heart attack, myocarditis, pulmonary embolism, acute pulmonary disease or infection. And the next thing you want to do is get an EKG. Factors or features that make atrial fibrillation more likely is if there's an absence of discernible P waves, there's irregular RR intervals. That's the interval between the R waves of consecutive QRS depolarizations. So if they're regularized, this may represent an escape rhythm and complete heart block. Next thing is a TTE. So this is a transthoracic echocardiogram. You can assess for the left ventricular function. Is there enlarged left atrium or right atrial size, which predisposes to atrial fibrillation? Is there a valvular abnormality, such as mitral regurgitation or aortic stenosis or mitral stenosis? Is there pulmonary hypertension? Is there a left atrial thrombus? This is actually better visualized with TEE or CT pulmonary vein than the chest x-ray. So you want to evaluate, is there any pulmonary parenchymal processes and pulmonary vasculature and edema? And then labs. So you want to check for TFTs, LFTs. TFT stands for thyroid function test, LFT stands for liver function test, BUN, creatinine, CBC, NT-proBNP, BNP. These are important for assessing the reversible causes of atrial fibrillation and also checking for any current signs of heart failure and any contraindications to anticoagulation or antiarrhythmic medications such as amiodarone. Next thing is a heart monitor. So you may need rhythm monitoring such as a Holter or Zio patch. You can consider a stress test if there's any signs or symptoms of ischemic heart disease. Signs and symptoms may be crushing, pressure-like sensation in the chest that radiates to the left arm or jaw. In female patients, this could be atypical signs such as nausea, vomiting. just general unease. And okay, so smartwatch notification. Nowadays you have smart devices such as the Apple Watch or Garmin watches. These have a positive predictive value of 0.84 for atrial fibrillation on subsequent simultaneous EKG in patients greater than 65. All right, let's talk about the acute management of atrial fibrillation with rapid ventricular response. You have a patient with atrial fibrillation, so managing in the inpatient setting is nuanced. First thing you want to see is, are they hemodynamically stable or not? So if they're unstable, typically this is a systolic blood pressure of less than 80 with rapid ventricular response, with signs of shock such as altered mental status, cool extremities, or pulmonary edema or angina. You can start with synchronized cardioversion with 150 jolts of biphasic shock. If pressors are needed, phenylephrine is the first line. Also, higher heart rates are more likely to cause hypotension alone. Lower heart rates may cause hypotension if there's systolic or diastolic dysfunction or decreased preload. So if the patient has rapid ventricular response and atrial fibrillation but is peristable, this is typically between systolic blood pressures of 80 and 90, you can carefully attempt the low-dose beta blockers or calcium channel blockers with concurrent IV fluids if pulmonary edema is not a concern. You can consider blood pressure sparing medications such as amiodarone 150 milligrams IV over 10 minutes, repeating up to once if needed, and drip at 1 microgram per minute. Remember, if there's evidence of left atrial thrombus, this can dislodge and cause an embolic stroke. So before you cardiovert, it's important to get a TTE. Digoxin can also be given IV 8 to 12 micrograms per kilogram divided in 3 doses. The max is 1.5 milligrams in 24 hours. You can check the digoxin level 6 to 24 hours after load with a goal of less than 1.2. You should adjust for creatinine clearance and wait for drug interactions. Contraindicated warfarin if there's an accessory pathway. So typical signs of an accessory pathway is wide complex tachycardia. So another thing is, if the patient is in atrial fibrillation, rapid ventricular response, but is hemodynamically stable, typically systolic blood pressure greater than 90, you can do rate control. IV medications are preferred if greater than 130 heart rate and symptomatic. You can follow with the oral agent once the rates are controlled. So medications that are used are magnesium 2 to 4 grams plus nodal agents that increase the success of the rate or rhythm control. So rate control is first with beta blockers such as metoprolol with an IV bolus of 2.5 to 5 micrograms over 2 minutes. You can repeat as needed every 5 minutes with a max dose of 14 milligrams, or oral dose such as tartrate, metoprolol tartrate of 6.25 micrograms every 6 hours. So be cautious if there's severe bronchospasm and with rapid escalation in patients with acute decompensated heart failure. So you can also use calcium channel blockers such as diltiazem with an IV bolus of 0.25 micrograms per kilogram over 2 minutes. Repeat as needed every 10 to 15 minutes. The oral medication delivery can be given fractionated. That means breaking up over several doses throughout the day, up to 360 milligrams total daily dose. You can reduce the dose with hepatic or renal impairment. And also remember, for patients with ischemic heart disease or left ventricular ejection fraction less than 40% and acute decompensated heart failure, you want to avoid calcium channel blockers. So remember, in all three of these situations, you should correct the underlying etiology whenever possible. If there's any reversible causes, reverse them. So that is rate control. If rate control isn't effective, the next step is cardioversion. So remember, for cardioversion, the risk of a thrombus breaking off and causing an embolic stroke is high. You want to make sure there's no interruptions to anticoagulation for 3 weeks prior. The indications for cardioversion are classified into urgent versus elective. Urgent indications are ischemia and organ hypoperfusion, symptomatic hypotension, or severe pulmonary edema. Elective indications include new onset atrial fibrillation or unacceptable symptoms from persistent atrial fibrillation. So the first line for cardioversion is synchronized electrical cardioversion, which you start with 150 grams biphasic shock and increase the energy if normal sinus rhythm is not achieved. The second line is chemical cardioversion, in which the success rate is higher for acute atrial fibrillation less than 7 days versus longer duration atrial fibrillation. So anticoagulation applies to both chemical and electrical cardioversion. Before you cardiovert, make sure to check the duration of the atrial fibrillation. If the atrial fibrillation duration is less than 48 hours, you can proceed without anticoagulation. If the AFib is longer than that or undetermined length, you can anticoagulate for 3 weeks prior to cardioversion or obtain a TEE CT pulmonary vein prior to cardioversion. And if those are negative, you can proceed with cardioversion. Proceed with cardioversion. After the cardioversion is done, you'll need to anticoagulate for at least 4 weeks after the cardioversion. Anticoagulation beyond 4 weeks after reversion to normal sinus rhythm is based on CHA2DS2 scores and HAS-BLED scores. The risk assessment for anticoagulation, this is for personalized medicine. So the CHA2DS2 score is for the indications for anticoagulation. C stands for CHF, H stands for hypertension, A stands for age between 65 and 74, D stands for diabetes mellitus, S stands for female sex, V stands for vascular disease, and you have 2 points for these conditions. If the age is greater than 2 points for greater than or equal to age 75, and 2 points if any history of stroke or TIA. So if a score of 0, there's no anticoagulation. If there's a score of 1 in men and 2 in women, it's based on clinical judgment, leaning towards using the anticoagulation. Greater than 2 is definitive anticoagulation. The exceptions to this decision making is for HOCM, hypertrophic obstructive cardiomyopathy or mitral stenosis. Next thing is HAS-BLED score. So the HAS-BLED score is for risk stratifying bleeding. Remember, anticoagulation increases your risk of bleeding, so this has to be factored into the decision. H stands for hypertension with systolic blood pressure greater than 160. A stands for abnormal renal function with creatinine clearance less than 50. L stands for liver disease such as cirrhosis or bilirubin 2 times upper limit, or AST, ALT, alk-phos greater than 3 times upper limit. S stands for stroke. B stands for bleeding history or labile INR. Labile INR is essentially like a benign INR, one that's typically less than, I think, 1 or 2, but fact check me on that. And E stands for elderly greater than 65 years. A stands for antiplatelet meds or alcohol or other drug use. Score of greater than or equal to 3 suggests using caution when considering anticoagulation. So the anticoagulation, you should consider the atrial fibrillation burden when estimating the stroke risk. Subclinical atrial fibrillation is also associated with increased stroke and systemic embolism. So in these patients, the anticoagulation reduces the risk of ischemic stroke, but increases the risk of major bleeding. So it's a risk-benefit decision. So to choose between DOACs and warfarin, DOACs such as dabigatran, rivaroxaban, apixaban, and edoxaban are recommended over warfarin in all except atrial fibrillation due to valvular abnormalities, moderate to severe mitral stenosis, HOCM, or mechanical valves. The reason for this is warfarin can cause bleeding and will need to be titrated very carefully and observed in the lab. So warfarin may be better than rivaroxaban in rheumatic heart disease. DOACs decrease the risk of stroke mortality and intracerebral hemorrhage. They increase the risk of GI bleeds, and apixaban has the lowest GI bleed risk. Dosing will be covered in a separate video. So for patients with renal impairment, if the patients have a creatinine clearance of less than 15 or on dialysis, can use either warfarin or apixaban. Bridging anticoagulation will also be covered in a separate video. Left atrial appendage occlusion. So the left atrial appendage is the source for at least 90% of thrombi in patients with ischemic embolic stroke due to atrial fibrillation. The Watchman device is a device that can be placed in the left atrial thrombus that can prevent the stroke by basically preventing any coagulation from happening. You should consider the Watchman device if there's a contraindication to long-term anticoagulation. Anticoagulation can be discontinued six weeks after the left atrial device is implanted. So surgical occlusion is also another operation that can decrease the risk of stroke and systemic embolism. Basically, you go in there and you alter the left atrial appendage so that it's likely to not cause any emboli. So there's a grade 1A recommendation with patients with CHA2DS2 score greater than or equal to 2 undergoing cardiac surgery in addition to continued anticoagulation. Long-term rate versus rhythm control. If the patient is symptomatic with atrial fibrillation, in the inpatient setting, rate control is preferred over rhythm control. But if the patient continues to be symptomatic, outpatient, they can be transitioned to rhythm control. Traditionally, the rate control was considered non-inferior to rhythm control, but the latest guidelines have shown that early rhythm control can reduce the burden of atrial fibrillation. So rhythm control is using antiarrhythmics and atrial fibrillation ablation, and is superior to usual rate control for patients with recently diagnosed atrial fibrillation and concurrent cardiovascular conditions. You can consider rhythm control if the patient has persistent symptoms like I've mentioned that impair the quality of life and age less than 65 or comorbid heart disease. You can monitor the atrial fibrillation burden by using a device such as a Holter monitor. There's also implantable devices. And the restoration of normal sinus rhythm may lead to increased quality of life and exercise performance. So then rate control. So beta blockers are superior to calcium channel blockers in achieving rate control, either alone or in combination with digoxin. Digoxin alone is moderately effective at controlling the ventricular rate, is ineffective in patients with high adrenergic tone. So long-term digoxin is associated with increased mortality in atrial fibrillation patients. The targets for rate control is lenient rate control with a resting heart rate of less than 110. Strict control is better in patients with younger patients or patients with heart failure. Basically, in these patients, for the younger patients, they have a long lifespan, so controlling their heart rate would lead to better outcomes over the course of their life. And patients with heart failure, their symptoms are basically due to inadequate perfusion of their distal organs due to the lack of the heart pumping adequately. So controlling their heart rate is effective in those patients. So contraindications to rate control are any evidence of pre-excitation syndrome on ECG. For these patients, IV procainamide is first line. There's a cautious use of rate control in patients with high degree heart block. Calcium channel blockers should not be used in patients with evidence of ischemic heart disease. So rhythm control. So if there's no structural heart disease, flecainide, propofol, dofilitide, dronedarone, sotalol, imiodarone can be used. For patients with structural heart disease, if they have coronary artery disease, dofilitide, dronedarone, sotalol, or imiodarone can be used. If heart failure or left ventricular hypertrophy, imiodarone or dofilitide can be used. If there's also a pill in pocket approach. So basically, these are patients with recent paroxysmal atrial fibrillation and infrequent episodes of atrial fibrillation. You can basically give them a pill that they can take when they have an episode that can decrease their atrial fibrillation and convert them to sinus rhythm while they're having an episode. As needed, flecainide or propofol plus beta blocker or calcium channel blockers instead of prophylaxis is better. So catheter ablation is also a safe and effective rhythm control strategy with decreased long-term atrial fibrillation recurrence compared to antiarrhythmic drugs. Ablation in patients with heart failure reduces the morbidity and mortality and improves the psychological distress. AV nodal ablation with pacemaker is indicated when the pharmacological rate and rhythm control is not achievable. So let's talk about atrial flutter. So this is a very similar pathology, so I'll just discuss it here. So on the EKG, there are characteristic sawtooth P waves. The atrial rate is between 250 to 300 beats per minute with a typical 2-to-1 conduction. So that means 2 P waves for every 1 QRS wave. The ventricular rate is typically around 150, though this can be variable. It can also have a 3-to-1 to 4-to-1 conduction. If there's a 1-to-1 conduction, this can precipitate ventricular tachycardia or ventricular fibrillation. So there's two main classifications of atrial flutter. So type 1 is typical, in which there's a reentrant loop in the right atrium via the cavo-tricuspid isthmus. This is basically between the right atrium and right ventricle. So counterclockwise rotation is more common with inverted flutter waves in 2-3 and AVF and upright flutter waves in V1. Clockwise rotation is less common with upright flutter waves in 2-3 and AVF and inverted flutter waves in V1. Type 2 is atypical and does not meet criteria for type 1, often faster and refractory to ablation. So anticoagulation is similar in atrial flutter. Also, thromboembolism is less likely. Rate control is similar, but typically difficult to control using rate control for atrial flutter. Rhythm control, so ablation is superior to antiarrhythmic drugs. The cavo-tricuspid isthmus ablation is more than 90% effective at 1 year. However, prophylactic ablation during the pulmonary vein operation for atrial flutter patients does not reduce the incidence of atrial flutter or recurrence of atrial flutter. And that is atrial fibrillation and atrial flutter.